welcome to our February Integrated Care Partnership meeting. Lovely to see you all, and I hope the weather is going to improve for you all. Certainly the amount of rain and different amounts of snow that different zones have experienced over the last 24 hours has been interesting and always challenging, of course, for services. So let's kick off though. Just a reminder to everybody that we are live streaming and will do throughout the morning. So a big welcome to you all, of course, but to our many guests and speakers this morning, which are too many, I think, for us to introduce without taking too much time. So just welcome to you all. But I'd specifically like to mention a big thank you from us all to Andrew Reid from Suffolk County Council. Of course, you're aware that Andrew is co-chair, or was co-chair of the ICP. And with the changes at Suffolk County Council, he is no longer. So perhaps we could note in the minutes a great big thank you from us all to Andrew for all the work he's done and his commitment and enthusiasm to the integrated agenda. And then also we should then exchange a welcome, I think, or give a welcome to Craig Rupert, who's going to be replacing him. Susanna and I have got a meeting next week, an intro meeting with Craig, to brief him on the agenda and the way we try and work, and hopefully Craig will be able to remember meetings going forward. We've also got 3 new members joining us this morning, so welcome to Vicky Joffrey from the University of Essex, to Michelle Martin from the University of Suffolk, and Simon Harness from Essex Care Association. Really good to have you all on board, and welcome to the ICP. We've got a number of apologies and deputies present. I'm not going to go through more, we don't usually, but just to say thank you to all those who have given apologies and sent a deputy, all noted and will appear as always in the record. Now, today's meeting, as you will have noted from the agenda, is essentially in 2 parts. It's actually in 4 parts in the agenda, but the 2 parts really are parts 1, 2 and 3, the formal business, which is important and very engaging as always, but particularly today in what is essentially the second part after the break, but it's actually noted in the agenda as part 4, we're going to have the first of our regular discussions, which we promised ourselves at a previous ICP meeting. We promised we'd have a regular discussion on left shift. So that's what we're going to do after the break today in 2 parts. First of all, demand and capacity from Alex Roy from the ICB presenting, and then the case for investing in community care from our colleagues at Carnell Farrow, which we very much look forward to. And Susanna will give a more fuller intro to that session before we start. So that's today's next item, declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item other than those of which we're aware? Susanna, over to you.
So I should declare that for the item from Healthwatch Suffolk, my daughter is the Watch lead at Healthwatch Suffolk, so she's been involved with that research.
Excellent, thank you very much for that. No other hands raised, so we'll take it that there are no more. In which case, moving us on to the minutes of the last meeting, 8th of December, seems a long time ago all of a sudden, doesn't it? The meeting which John Spence chaired in his capacity as co-chair. There are 6 pages to the minutes, but I wonder if we can take them en bloc. Has anybody got any points of accuracy in the draft as you have received? And again, I see no hands raised, so shall we resolve that the draft as presented from the meeting of the 8th of December 2023 is a true and accurate record? All agreed? Great. And then we have to, final item in this formal business area, let's receive the ICP workbook, as we always do. Includes the matters arising and the action log, and actually all the history there and the work that was progressed over over recent months. Everybody happy to receive that as presented? Any questions or points on it? Otherwise, received and noted. Thank you very much all. That then takes us on to the next item, item 3, the update from the last formal ICB meeting on the 30th of January. And Ed is one of the people who's had to give apologies today because he's been pulled away to another meeting that he didn't have any choice about. But Susanna, you've kindly volunteered to give the update on Ed's behalf.
Indeed. So, so first of all, Ed was really disappointed to be missing the ICP meeting this morning, and he said when I spoke to him that he's hoping to join the meeting a bit later on, hopefully in time for the discussion around the shift towards the end. There were 4 items that he wanted me to just highlight on. So the first was that at the last meeting of the ICB board, which was last Tuesday and took place in Bury St Edmunds, one of the points that he noted was the kind of thanks from the ICB board's perspective to all of those who have been involved in the system response to industrial action in the new year. Then in terms of the meeting itself, of course, there was all of the usual what I call transactional business. There's a lot of process that takes place at the ICB board with signing off annual accounts and all those sorts of things. And all of that is in the papers which are published online. There was a really interesting conversation and update from the great progress that's been made around the unscheduled care coordination hub. That was very much welcomed by the board, and going forward there'll be more work to do in there. And also a really interesting update from West Suffolk on the work around virtual wards. This was a clinically led presentation, and I think a key message for the ICP is what the board really highlighted with the opportunities to explore the opportunities for virtual working with wider system partners. So one point that was came up was the importance of really learning from family carers about their experiences of virtual wards, but also really working with social care providers around kind of how virtual wards could work in partnership more with social care providers. So those were a couple of kind of key highlights. As I said, papers for the ICB, they're always posted online and recorded the meetings as well. So if it really is a wet weekend, there's all of that awaits you if you care to look it up. But for now, I'll hand back to you, Will.
Thank you, Susanna. That was really helpful. And yes, it was a very busy agenda, wasn't it? And you pulled out the highlights there. But as you say, a huge number of governance and mechanical and process items also covered. Any questions or points from anybody on that update, or are you content to move on? Everybody happy? Wonderful, lovely, thanks very much. In which case, let's then go on to the Suffolk North East Essex draft dental plan. I'm going to go to Peter, I think, to introduce this, but also I'm not sure whether he's with us or not yet. Maybe he is. I think we should also be welcoming Nick Barker. But Peter, I'll leave it to you to do the mechanics of the intro and to run this item. All yours.
Yep, thanks, Will. I hope everyone can hear okay. My name's Peter White. I'm the West Suffolk Alliance Director, but I'm also got the Executive Dental Lead for us for SNE. And I'm just going to share my slides, and I'm hoping that Nick Barker, one of our dental advisors, can join us, but he's, as ever, double running. But I'll give the presentation then and take some questions at the end. There's lots of detail in here, so I will bring attention to some of the detail, but there is an opportunity for everyone to fire questions. So I'll just share the slides. So just check that works okay, first of all. Have we got those?
Yes, it's there at my end, Peter. I don't know whether you can make it any bigger or not for people, but it's
that's as big as it gets. I think that is the slides. Yeah, is that okay?
Yeah, it's good. Thank you.
Great. Okay, well, I'll fire away. So, as a bit of context, I think as everyone knows, that poor oral health is one of our key drivers of inequality in SNE and nationally. And we shouldn't think of oral health as being separate to overall body health. And there's lots of evidence that points to these conditions on the right-hand side, physical conditions, which directly link to poor oral health. We are getting a latest dental needs assessment, and there is a consultant in dental needs in dental public health who works across the region, and we have someone who works specifically for us in in the east, and we're waiting for that latest update on our position. But I've put here some of the data that we showed in the JFP that shows that broadly we've got strong oral health in our children in Suffolk, less so in Essex, with variation by geographic populations. Regional data points to particular propensity for high decay in Asian children, and there's some positive news with regards to oral cancer rates are at a national average, but we're really hoping that we're going to get better, more localised data from our work with our regional public health dental consultant. Just a reminder, I know it's just the basics. This is not a free point of view service. What we have as commissioners is completely different for dental. We don't have a budget for the whole of an NHS dental service for every resident of SNE. We have it for effectively half of the population, and even then, those that you can access a dental NHS dental practitioner will still be paying quite high fees to access that service. And there are lots of private options open to patients alongside this. So it's one of the few aspects of NHS care that is a mixed market, and it's just really important to say that at the start. We've got the data on our access to NHS dental services, and it's a long-standing problem, and it's worsened during COVID, and we are below the England level in SNE. And the graph on the left shows that in the last 12 to 24 months, 38.7% of our population accessed NHS-funded dental services, down from 51% in 2019. So that's around 100,000 people who are not accessing NHS dental services who were previously. On the right-hand side, we've got the measures of activity, which is courses of treatment or units of dental activity. And so it shows that the amount of dental work that's being done is getting back to pre-COVID levels, but that's being done on a smaller population. And there are various theories about what's going on there, but it's probably catching up for that same group of people who are on the dental list. And whilst we don't operate dental lists, many dentists aren't not accepting new patients. So if you're in the system, you're getting a service. If you're not getting a service. That's a very broad general summary of where we're at as an NHS at the moment. I've just put on this slide the activity. So we've got a contract. We contract for 1.4 million worth of units of dental activity, and a unit of dental activity is basically one unit is a dental checkup, and there are clusters of different levels of treatment that dentists can claim for that count as multiple dental units for payment. And you can see that 74% of our activity is delivered year to date in 23-24, and that varies across our alliance populations with regards to the extent to which dentists are fulfilling their contracts. We'll come on to what's driving that in a moment. And we have on average 2,000 people a month contacting our 111 service, which could be trying to get a routine dental service or with an urgent dental problem. And we have many presentations at A&E and GP practices, which I'm hoping we can get better data on to measure the numbers that's happening there. So as we try to improve our dental health, we should see those two bottom numbers go down, hopefully, in terms of where people are presenting in the wrong places. So why have we got a dental access problem? This is well rehearsed in the national press, but just for it's helpful to put it here. We know that the contract framework that was developed in 2006, it's recognised as not really working very well. And that's been recognised by the Health Select Committee, and it focuses too much on invasive surgical treatments rather than focusing on health promotion and prevention. It also rewards treatment for regular attenders, and so you end up with a system that doesn't really meet the costs that dentists are facing with regards to looking after vulnerable patients, and especially if you have a backlog of problems in someone's mouth, the contracts are especially effective at dealing with those circumstances. And also, We're not where on the previous slide I was showing you underspending in practices. We're not able to take that budget back from dentists until the following year, which really hinders our ability to go out for a procurement to secure new providers who might be more able to secure and deliver that NHS dental service. And the commissioning system, where the commissioning teams have been made smaller and smaller every year at a national level, they've not had time to do any of this development work. And so we've really got behind the curve with regards to our dental circumstances. And so this table is quite clearly showing you that this is the number of dentists who are registered on the list to provide NHS dental services in SNE, and it's been reducing since 2018-19 each year pretty much. And you can see it's the younger dentists that are the ones not participating, or the numbers participating is reducing. So this is a problem, and if that carries on, we're only going to see things deteriorating rather than improving. So on the positive side, there are opportunities. We've got some new flexibilities to use the contract in a more smart way. We're now able to try and train a wider professional dental team, as we are in every other aspect of health. And they're recognised under the contract, or will be shortly, to qualify to be making claims for NHS payment. And we're going to be able to withdraw these underperformance values subject to legislations, start the process April 24, with the view to taking the money out permanently from April 25 for long-term underperforming practices. And also we've got delegated powers now as an ICB, and we can operate more as a speedboat to do what we want to do rather than some of the more cumbersome national processes. And we do have underspending budgets that we can redeploy. And I've just shown you the total budget, around 54 million that is available to us in SNE each year at the moment. And the new national guidance requires us to spend that in a dental setting. Now, that is easier said than done, as you'll see as I go through the presentation. Final aspect of challenges, we also need to have a footnote on secondary care. We don't have long-term consultant appointments of oral maxillofacial surgery at ESNEFT, and we have vacancies at Norfolk and Norwich and MSE. We've got limited regional specialties, people are travelling further, and the networking needs to be more developed between those trusts. And ultimately, we don't have a dental school in the east of England, which is part of what's driving why we have greater problems to recruit in east of England overall. And also, we haven't really done enough to commission specialist primary care dentists with special interests who can move up their licence to prevent the need for certain conditions needing to go into secondary care. And we have some long orthodontic waiting lists, so relatively some of our orthodontic access issues are nothing like as bad as more general dental problems. So in terms of what can we do about this as a system? And we need to work across the oral health continuum, and a pyramid that we use in so many other settings really absolutely applies in dental health, because so much of the dental presentations are entirely avoidable by upstream left shifts, we call this when we get there, work from a family level through self-help groups, etc. And so we need to be working across the board in our approach. And that means working with everyone in this in the ICP as partners for in the way that we're promoting oral health, working with our university partners for dental training, and rebuilding the relationships with our dental providers through contract flexibilities. And I think a common strapline is we need to put the mouth back in the body, because often we might spot oral cancers and all kinds of diabetes issues that a regular dental checkup system would have, but it has to be connected to a wider health system. And so we've already recruited to a team, and we've got clinical leadership to help us implement our programme. We have two regional chief dental officers in Tom Norfolk and Nick Barker, who work across the region, and Nick also works as a dentist, really active dentist and trainer, and many other things at the university in Colchester. And we've also recruited 4 senior fellows to help advise us across the 3 ICBs listed here on how we can move forward. We've increased the ICB team from 4 to 8 people, and they'll be coming into post in the next 2 months. And we're taking a multidisciplinary approach across the ICB to this, linking with our consultant public health colleagues. And we're working closely with our neighbours in MSC and Norfolk and Wavy, who have similar issues to us as coastal ICBs. There's a particular issue about recruiting and retaining the dental workforce for us all at the moment. And so what these slide sets out is our plans against each of these 9 areas where we need to move forward. And unscheduled care, I'll put us on the side here, crosses all of these areas. And I'll focus on a couple of them, Will, if that's okay, and then perhaps leave the rest of questions as I proceed through. So what are the main things that we're doing? Well, we've already started through our 2 county councils to commission additional prevention programmes that are in place in North East Essex and just starting in Suffolk. And that includes extra support into schools, targeted based on where there's evidence of greater oral health difficulties. And we're wanting to introduce into the health visitors 24-month checks, routine oral health checks as well, and also training early years staff. And this is, if you followed the recent dental recovery plan announcement this week, much of this also appears in what is coming through in the national expectation. And this is really important through this partnership forum to be stressing a partnership approach is needed here around how we can promote oral health in all of the settings that are available to us. But it's, also we've got an opportunity through dental connections to be promoting our general health messages. So if you can see high evidence of sugar use in the dental surgery checkups, well, that's a great opportunity for an every contact counts wider health signposting towards healthier lifestyles that is important for us. And you'll also have noted that we've got water fluoridation is coming back as an issue, and I'm interested to know what county council's roles is in this. And they've done it in North Yorkshire. Is that something that we should be doing in our councils? And that's just been come out in the recovery plan as well. Very much led on the council side of the house moving forward. So that's the high-level summary of the things that we are doing on the prevention side. On the workforce development side, we really want to ask key strategies is to broaden the dental workforce, and we're really fortunate. We already have strong in the University of Essex, one of the largest providers of training for the wider dental team workforce, and that is growing also in the University of Suffolk. And we've commissioned the University of Suffolk Dental Centre to start to combine NHS services with that training, because with all of those staff in training, they also need to have a good placement. And we want to try to build the connections of those staff with our dental practices to, when they qualify those staff, they're able to take up those new places. I think the role of the dental therapist in particular is an important one, the step below a dentist, and both in terms of training those staff, but also helping dental practices change the way they work, to think about how therapists can form part of their teams to help build this into the future. I've just listed this from a national slide just to give you an indication of the range of dental professionals that I think a lot of our workforce needs to develop in to support how we can meet this future demand. The next thing I just want to draw attention to is our priority groups. So if we're in a catch-up mode, we've identified the following on the right-hand side, these 11 groups where we have already put an offer out to the dental market to say we would please provide a service to this population. If you do, we'll pay you extra funds in recognition that this is a more complex workforce. There's extra costs over and above the current contract, and that includes in and out of our services. We've had some good initial interest from our providers in Ipswich and Colchester, and we're hoping to see some of those services start to take effect in April, and we're having to work a bit harder on the west of Suffolk and some other parts of Suffolk to try to get more interest. That reflects some of my initial comments with regards to the different strengths of our NHS dental market across us at SNE. So this is the heart of the plan, really, in terms of general dental practice, where the majority of our interventions are taking place. And we've got a suite of things that we are building, and this complements what's been announced in this week's National Dental Recovery Plan. There are new recruit incentives. They've been successful in Norfolk in using these, and they'll be coming out nationally, which is where dentists who are new to the NHS would get a golden hello payment, and the national terms now mean 10k in the first year and 5k in years 2 and 3 for staying on the NHS services. I've mentioned the Suffolk Dental Centre, which we're hoping to see start in March, April, and we then, based on our needs assessment, will be running some procurements for those areas where we've got lower NHS capacity, to see if we can either give extra funds to existing providers or get some new providers into the market to try to grow our capacity. There'll be 8 to 5 services 5 days a week in more remote communities, and in our larger population centres, we'll be seeking to get 8 to 6 on weekend services to try to increase our capacity. And then also, really importantly, we need a long-term contract strategy with our 150 existing dental providers to understand why it is they're not providing more NHS services than they're able to at the minute, and what it is that can make the difference. So it's doing both of those things, working with the existing dental market and trying to bring in more providers that can help us to increase our capacity. We have commissioned the Suffolk mobile service that is starting this quarter, and then we're expecting national. We've been identified. SNEE's one of the national areas for the dental recovery plan to get resources and an expectation to have a van that can travel to areas where we've got really poor dental access as an urgent service. It's really important to point out this isn't. This is a short-term fix, the van, and really what we want is to have an established service where people can have their oral health stabilised and establish a regular, long-term relationship with their dental provider. So this is already a short-term fix, the van, where we can secure it. And we're also looking to commission additional Tier 2 minor surgery. So this chart sets out our ambition that if we were successful with those initiatives, we would be able to, we hope, close our 25-28% gap on the current contracted activity to try to make sure that every pound we've got is going out into the market to secure dental access for our population. I will skip over some of the main slides in view of time, Will. So orthodontics, we're having a needs assessment, and we'll look at where the waiting lists need to be reduced. But I say we have a relatively strong position at the moment, and credit to our orthodontic providers for that. We have 2 community dental providers looking after particular groups, one in Suffolk and one in North East Essex, and we're doing a review of their contract, and they're providing the mobile service in Suffolk. And for specialist secondary care, I'll just hover on this. We're looking to build a network with Norfolk and Norwich and MSE and Cambridge University Hospital to provide more recruitable posts. And the idea that it would be Norfolk and Norwich coming into SNF sites and potentially West Suffolk site to provide that oral health secondary care services or maxillofacial services from those sites. Currently, SNF are out to an insourcing procurement to secure that service in the intervening period, but all of this is entirely dependent on getting attractive jobs and getting new consultants into the area. Adam Brooks, we're fortunate, are being successful in a pipeline of training new consultants. I'll just click to the last 2 slides in the interest of time. So where are we in? So the next steps, we're finalising this plan. We really would welcome people's comments on the plan today and afterwards. We're going to have a dedicated session with our Health Watch colleagues to talk this through, because I know this is at top of your post bags, and we'd welcome partner feedback and offers of support ahead of us finalising this plan in a bit more detail at the board for 26th of March. We'll then do some political briefings, because this is, again, top of the post bag of our councillors and MPs, and then we will be presenting to our health and wellbeing boards in May.
Peter,
lots I've covered there, Will.
Yeah, lovely. No, thank you, Peter. It's a big agenda and a very important agenda, of course. And while you were speaking, Nick Barker has joined the meeting, so welcome to Nick. Peter, I know we do want some time for discussion, but Peter, do you want to introduce Nick and see if there's any additional comments from
Absolutely, Nick? Yeah. I mean, so we're really lucky to have Nick on our patch, and I'm perhaps leave Nick to introduce himself. But as I said, we're really being hand on clinicians and managers trying to work out what's going to be successful. But over to you, Nick, to say perhaps some comments as well.
Thanks, Peter. I think thanks, Will, as well. Nick Barker, probably by way of introduction. So, as Peter's already explained, I'm one of the 2 regional chief dental officers working closely with the SNE ICB alongside Tom Norfolk, and I have to say it's excellent to be working with such a proactive and well-engaged ICB and working well across MSE and Norfolk and Waveney as well. So that's excellent to see how things develop. I'm the regional chief dental officer, but I'm also the deputy chief dental officer for England, and I'm a professor of oral health sciences and periodontology at the University of Essex. So various connections in. I think first thing is excellent. We've talked Peter well, because his explanation of dentistry as a whole was spot on, and I don't think I've got too much to add to that. In that he certainly seems to have picked it up. I think the recovery plan is the key element. I noted Peter on one of his last slides says it's due out, and it did come out, as many people probably spotted, in the middle of the week, with about 3 days of turnaround. So it was a bit busy at the beginning of the week. I think the recovery plan will help. But the way that we would look at this really is that it would be much better as an ICB of us to be working ahead of the recovery plan rather than relying upon it, because it helps in part with, say, the golden hellos and some preventative mechanisms within public health as a general rule, which would be really good. Water fluoridation being a key one was noted. But I think we've also really got to open up these dental services. And as Peter has correctly put it, the dental contract was very much slated by a Health Select Committee earlier in the year, of which I was one person giving evidence. And the report from that says that basically UDAs do not work. The recovery plan that we've got is in place for only 13 months. The main view is that at the end of the 13 months, we'll move into a further contract reform basis, which should be what is happening during the 13 months. So I think the plan that Peter's presented should be commended. And if we can move into a flexible commissioning model that moves away from the UDA. Now, the UDA is good in part. It helps people who are regular attenders and it just turns over treatment. But anybody new into dentistry or hasn't seen a dentist for 2 years, we really need to look at ways of getting those people back onto a prevention and health stabilisation mechanism. And I would re-emphasise Peter's other comments around dentistry, put the mouth back in the body, because we really need to integrate with cardiovascular disease services, diabetes, head and neck cancers, pneumonia, dementia. All these are systemic inflammatory marker systems and diseases. And we know, for example, there's irrefutable evidence that if you improve people's gum health, then their diabetic health improves by about 0.5 on their HbA1c score. So we really need to get that joined up thinking going. And that's probably enough from me, Will. I've just grabbed a couple of minutes, but hopefully some questions.
Thank you very much, and thank you for joining us today. And also thanks, Peter as well. You both referred to the National Recovery Plan, so I won't cover that at all. Really, really important. And also, Peter, thanks for flagging the leading work at the University of Suffolk and so on. So a couple of hands raised. Let me go first of all to Ruth. All yours, Ruth.
Yes, thank you. So here is the Suffolk GP Federation today. I have been very fortunate to speak to Lorraine and Ash from the Dental CIC, and I think really valuable conversations. Absolutely support that, and also they put me in touch with Sarah Hurley to help one of the sixth formers locally who wants to be a dentist. I sat in on the hour-long conversation she had with him, and just completely mind blown about the about dental being broader than that. You know, it's not all drilling and filling, and the different aspects of it. And I think there's a real opportunity here for when we're building something to build it really well. Definitely putting the mouth back in the body, and we've had subsequent conversations last week looking at how we can in the Fed working in a fairly similar sort of space in the out of hours space, actually looking at that dental, but and then the more broader way when dental meets medical, I think is what I'm talking about, and how we can make that smooth as well. So we've got some ideas of things we might be able to do. So very happy to link up with you, Peter, on that if you'd like, because of other places where dental touches.
No, thanks, Ruth, and I'll say Peter answering that. I'm sure. Should we Peter would be totally in agreement with that. Should we take that as an action outside the meeting? Thank you very much for that, Nikki.
Thank you. I just want to start by acknowledging what a challenging area this is, but also commending Peter and Nick on what is a really comprehensive plan. I sit here feeling very reassured. Of course, we've got to deliver it, but I thought it was very comprehensive and well presented. Two things, which I'm sure the first one you've thought about, which is quick wins linked to innovation and underspend, and what are the opportunities to reach in rather than reaching out into communities. I note the Suffolk mobile unit, but actually what about Essex, where we've got some real challenges in North East Essex around dental care? The second point I wanted to raise is on page 16 around priority groups, and my request is, can we please add in children in need and children subject to child protection plans? These are amongst the most vulnerable children that we've got in the communities, and actually if we don't include them, we're doing them and ourselves a disservice. The numbers are quite small across North East Essex and Suffolk, but I think they receive statutory services under the Children Act. So I really think we should be considering them as part of the priority groups, and that would be my request. Thank you.
Thanks, Nikki. Two really good points there. Peter, let me come back to you before I move on to Belinda.
Yeah.
Are you, do you want to comment on Nikki's point?
Yeah, of course. Thanks. If I start with the children, I think that's good feedback, and I think we've got looked after children, but you're right, we can broaden that to the categories that you've defined, and I think and that's also including that care leavers. It's almost that those with higher needs up to 25 in a way, isn't it? And that could be a better way of defining it for ourselves. And then I think I think it's just I think we plan to have a mobile service in Essex too. We've got, I think in Suffolk we got ahead because that's where we ended up with Suffolk County Council. I think we took different priority decisions locally with our Essex colleagues that there would be more to be achieved through the prevention work. But now we've got this national plan, we will get started on that sort of short-term fix with regards to the mobile, with all the caveats that go with it. That when you leave the mobile, the most important message is so where do you go next? And we need to be able to point people to where to go next, rather than we just disappear into the ether. So that's it's just getting that bit of the transaction right. Yeah.
Excellent. Thank you very much. Good points, Belinda.
Thank you, Will. Peter, thank you for the presentation. It's so assuring to hear about all those changes that are on the horizon. So I'm obviously, as a number of you know, I represent 111, those 2,000 calls that you talked about there that come into us, for people who are either trying to access dental services or in some kind of distress about their dental pain, which so often presents for us as a disposition outcome of poisoning, because we have to ask them how many painkillers they've taken, and it goes over the recommended requirements for that. So Peter, I guess my raising my hand is about offer of help and support, particularly on tracking the impact through urgent care services of some of the things that are coming in place. We're currently receiving, 2,000 calls plus. Obviously, we run the dental CAS, so we've got dental nurses in the CAS, and I've spoken at a number of these events about what it feels like to be that dental nurse working in the CAS at present, and the verbal abuse they've had to deal with, but also patients threatening self-harm and suicide because of their dental pain. So I'm sure we would all love to track the impact of this work and what it means to those patients. So absolutely offering that help and support. And then there was some talk there about signposting as some of these new services come online or new approaches, making sure that our DOS reflects that will mean that anything that comes into urgent care services, we can get patients to those new or different services quickly and appropriately. Will be a great way to work together. So it's an offer of help, Peter.
Great.
Thank you.
Thanks, Belinda. And Peter, unless you say differently, I think that's offer help. Great should we say?
Thank you. I just wonder if we should just invite Nick in to perhaps comment as well on the last two questions as well. But thanks, Belinda. You're very much welcome.
Yeah. If it's okay, Nick, I'll come to you at the end, because also I see a number of comments in the chat which have been very helpful, and we'll capture those. The team will capture the chat comments as well. Let me go to Lucy, and I'll go to Nick and see if we can wrap. So, Lucy.
Thank you. And I echo others' congratulations on the development of such a comprehensive plan, because this really is a massively underfunded, but also hyper sort of media oriented programme of work. And I can appreciate how politically and financially challenging this is to develop. a couple of things. So one, obviously really, really pleased to see a whole load of information about prevention. And, I still get very upset about the fact that, extractions are the highest preventable reason for admission of children to hospital, and nearly 100% preventable as well. So, we've still got a huge amount of work to do. One of the things that I think we've missed slightly is we've talked about schools, but we haven't talked about 0 to 19 public health nursing services. There's a huge amount that health visitors, even midwives as well, when they're starting to provide pregnant mothers with information about oral health, can obviously promote as well. Again, we Public Health Commission that, so please do link in with Stuart and I. Fluoridation in water is a fascinating topic, again, hyper-political. I do think it is worth us exploring, but the reality is we need to explore it on a regional footprint because of the complexity of water supplies. But there is no reason why we couldn't sort of explore that with our DPH regional group and our regional director of public health. So if there is a willingness to explore this, and as I said, we must underestimate the political elements of this and the views about taking away choice, etc. But I think it's certainly worth us understanding what that would look like from a system perspective, and then we can obviously then garner support.
Sorry, Lucy, if I could just say on that point, sorry to interrupt you there, but I saw a lot of nods around the screen when you were talking. If you and Stuart are happy, would you take that forward?
Of course, I can take that, yeah. The East of England Public Director Public Health meeting, no problem at all. I think you will get mixed reviews almost straight away from the Director of Public Health, but I think it's worth us having a more focused discussion about it as opposed to quite a knee-jerk reaction, because I think we'll recognise the complexities of those discussions, and it would take years just operationally to mobilise, but I think it's something that we need to probably explore properly so that views are really genuinely gathered, so that we make a conscious decision as opposed to an assumption about whether it would be supported. But lastly, I think one thing that's missing though is comms. Actually, the reality around oral health prevention and oral health sort of maintenance is that it's simple, reasonably, and I say that recognising the challenges, affordable. But actually, people don't always know what best practice looks like, particularly if they haven't been to a dentist for a number of years. So is there something that we could do on a system level that just talks about what good oral health is for children, adults, and then people with dentures or other sort of oral health challenges? That actually is not that complicated, but if we drew together as a group of agencies, could be promoted through all of the anchor institutions, etc., just from a point of view of awareness raising and good practice.
Good point, Lucy. Yeah, and again, nods around the screen when you were mentioning that point. So let's take that as a supported comment by the ICP and put that in the actions log. Nick, I'm just going to hold you at the moment because Andy, I'm really glad you put your hand up. So thank you for that. Over to you.
Thank you, Peter. Thank you, Nick, and thank you everyone else behind the plan. It's been long awaited. Been talking about needing something like this, well, since the pandemic hit in 2020, and it is, as people have said, very comprehensive. I was going to mention two things. One was comms. Lucius just mentioned that. I'll just add to it slightly in that I think the public desperately need clear communication about what it is what they can do and should be doing in their own situations and what they can reasonably expect. That combination is really important because we still get far too many people who are sent round in circles that involve everything, including 111. And I think there needs to be a communications plan, a publicity plan, a campaign that explains that, because that realistic situation is something that they will describe because they were experiencing it. I think they need to understand, or they need to know that the system recognises this. And what we're planning to do and we are doing is great, but we need to keep people grounded. The other bit really is about how we're going to evaluate this, because there are two ways of doing it. I think you've probably got something in motion. Nick, you work at the university. There is that protocol, but you can actually think about other alternatives and use the Health Watch Local Health Watch, because as you both know, as you know, Nick, we've been involved in conversations with yourself and others, all the way back to early 2020. So comms really important, and evaluation.
No, good, both good points, Andy. Thank you. So, Nick, I'm going to come to you to close the discussion generally, and then I'll try and wrap and get us to move forward. Over to you, Nick.
Thanks, Will, and thanks everybody. Really, really helpful points, I think, on so many. I've made some notes. So, agreed. Water fluoridation, I think we really need to push ahead with that. We know from the 1960s when Birmingham was fluoridated, the reduction in dental decay, and that's a good example. Communications, absolutely agree, and we are working with our 4 senior fellows who are looking at a communications network, and will look to get communications out public facing, so that would be good. I put in a list of the vulnerable groups. I'm very happy if anybody wants to add to that list that I put in the chat that we should look at, because I think we really need to have a look at that. And part of our services should be an outreach service, not a mobile service, but actually that dental practices go out and reach out into the communities. And we've got examples of that in care homes and residential homes in Mid and South Essex, so that would be good. Data, absolutely with you, Andy. We need a good service evaluation. We'll definitely pick that up. And we are currently working with Queen Mary University of London as well, with a PhD student there who's also looking at some work on that. We've got some senior fellows, as I say. We've got 4 senior fellows, and we can run the work streams through them. We need to use our skill mix, so we need to use the full range of dental opportunities across all of our dental registrant groups, so the nurses and hygienists and therapists as well. And finally, I hear about finance, and the other opportunity we have on finance is we are allowed to flex up to 20% of any given contract, so we don't need new monies coming in. We use the existing monies and use a different model. And actually, we can push that even further. And I'm in a regular conversation with the directors of NHS England nationally of how we can do that. So I think we've got an opportunity to move, as Peter says, be a speedboat, not be a super tanker. So let's start acting like one, eh?
Yeah, that was good. Yes, I picked up your speedboat comments as well. It was a good one, wasn't it? And colleagues, I've let that overrun, as you will have realised, so we are running late. But I think that was a really, really important agenda item, and a great presentation, Peter and Nick. Thank you for both, and a great discussion. And also there's an element of left shift in what we know. We're going to have a left shift in the second part after the break, but there's a big element of left shift here as well. So it's so many buttons. We're asked to note, I think, that we now the draft dental plan now goes into a period of consultation, and the plan is that it comes back to the ICP board on the 26th of March in what is hopefully then a final form. So noting that we're in a period of consultation now, noting all the points as discussed today, are we happy to endorse the draft plan and the way forward? Everybody content? That's great. Thank you very much all. And also, by the way, thanks for some of the great chat, which I know the team will capture. So thank you for that. Let's move rapidly on then to the Suffolk dementia strategy. Now, Gail, I think I'm coming to you next, and Gail, and also we have Jason Joseph as well. So Gail, shall I start with you and leave it to you to manage this item, just conscious of time as well. So all yours.
Okay, thank you very much. Thank you for having me here today. I do have a presentation. I understand we're short for time, so I'll try and go through it quite quickly. Hang on, just bear with me a minute. Sorry, I'm going to share my screen first. Apologies.
Don't worry.
No, that's not what we need. Just bear with me. Okay, let's just find the right one.
It's always the way when you're under pressure, don't worry.
Right. Okay, hopefully you can see this. I can only see you, William, so hopefully you can see this.
That's my screen, Gail.
All right, thank you, Jay. Thank you very much. Sorry, apologies. Thank you. I'm here today to talk about the dementia strategy. We have a final version, and Susanna kindly invited me here today to discuss this with you all. So thank you very much for your time. If I just briefly talk you through the slides, the strategy came about from the Dementia Action Partnership, and it was a commitment to provide a dementia strategy. The dementia strategy has built on the fantastic work from Healthwatch, and that has been reflected throughout the strategy. It's been co-produced completely throughout, and there's been a lot of engagement across the whole system in Suffolk and Waveney. Whilst we've been doing this work, there has been a shift in interest around dementia, and also a real focus around reducing stigma, early identification, and highlighting the needs of carers and families. We have really listened to the people of Suffolk and really tried to understand what they really need. And we're currently in the process of taking this final strategy through the governance process, and for its final sign off on the 14th of March at the Health and Wellbeing Board. Our ask is to basically just make sure that everybody's completely signed up to it, and that the whole system is part of it. So thank you. Jay, I don't know if you want anything else to say, or I'll just carry on. So just interrupt me if you want to say anything else.
I'll interject if I need to, Gail.
Okay, sorry, thank you. So just to give you a little bit about co-production. As you can see here, this is the most important thing to me, was that this strategy was co-produced. So we really worked hard with all our partners, really listened to people, went out into the community and built on the work that the Healthwatch report did. So I'll just go through this quickly. So out of this, we had priorities and outcomes. We based this on the NHS England framework for dementia, which is preventing well, diagnosing well, supporting well, living well and dying well. Through all our co-production, everything goes back to the groups to sensor check that we're providing what people with dementia and their carers need, and we followed this particular pathway. So from this, we have particular outcomes from the dementia strategy, which is preventing well, and that's raising awareness, understanding and information. And as you can see, there's some points, some further granular detail. We have diagnosing well, which is improving the assessment and diagnosis. We have supporting well, which is increased need as symptoms develop. We have living well, which is providing support for people with dementia and their families. And we have dying well, which is having the opportunity to prepare for end of life. And if we look forward, so the deadline was always quite challenging because we wanted to make sure it was co-produced and fully co-produced, and there was wide engagement and consultation. So the next steps is to co-produce a meaningful action plan and outcomes between January and the end of October, when my role ends. And we have made the dementia strategy ambitious to reflect the needs of people living with dementia and their carers. There may be a likely resource in the future. I understand there's no particular funding at all, so apart from the services that we have got, and we will be looking at them in detail, which Jay can reflect on in a moment. But what we can do immediately is reduce stigma, increase diagnosis rates, get understanding what people need, which is information, advice and support, and make sure that they get that, and really sort of think about across the system how we can work on short, medium and long-term actions. And as part of this, there is an action plan which will be drilled down for each alliance, East, West and Waveney, and be also supported by the age well domains and the integrated neighbourhood teams. Jay, I don't know if you want to say anything else?
I'll just add that Gail's done a fantastic piece of work, and she's tore through that. We took on speedboats very quickly. I think it's shown some great integration across the system, so it's an integrated strategy. Health and social care, public health obviously have been hugely involved, and obviously it's based on the work of Healthwatch. But as Gail says, it represents the views
families and people who are living with dementia at the moment, and I think that's something we can be really proud of. It also reflects some challenges for us as a system, so we're well aware of that. We're aware of the current financial context that we're all living in. So those actions will reflect some of that work. But I think what Gail's reflected on and the conversations she's had across the county in the last couple of years is around what we can do through our communities, how we can support our communities in a much better way, how we can communicate support for people with dementia, and how we can work with our voluntary community sector to really support people where they live, to live the best lives they possibly can. And I'm just really minded to look at that the end of life, dying well. That's something that we've done a lot of work on, and we're keen to progress further with our hospice colleagues to look at actually, living grief is a real big impact for people with dementia and their families. And I think the action plan will reflect some of the work we do around there. That's something that's been highlighted quite a lot in the conversations we've had. So the plan is obviously to get your endorsement today as a board chair, and obviously free to take any questions or queries or suggestions you may have.
Jason, thank you. Gail, thank you very much. Andy, you've had, from a Health Watch point of view, there's been a great role here as described in the paper from especially co-production point of view and so on. Do you want to make any comments? And over to you if you do.
Is that for me or Andy? Or sorry.
You're still on mute at the moment, Andy, or are you saying no, you don't?
Well, yeah, I wasn't expecting to be asked that.
No.
Well, I haven't prepared, but
don't worry.
I put something in. I put something in chat. Gail has lived and breathed this from the outset, and Gail has been instrumental in working with all our partners and people and the public, family carers and people with dementia for many years now through what is the Suffolk Dementia Forum. And one of my worries is what happens after October when Gail said that the post ends. And I think there's a risk we lose a lot of experience and knowledge of this area of work. But in answer to your question, Will, what we discovered in our report, and we spent a year doing this, speaking to an awful lot of people, is that there's a huge gap in what it is that we need to bring about. Experiences of families and individuals really vary so much. It's very polarized. Everything from people who will say that their loved one has been looked after for health and social care really, really well. They know what to expect. They're being supported, all the way through to the other extreme, where it's almost, as soon as that dementia word is used to describe an individual's condition, it's almost an end of life thing, and it's treated that way. And everything between that point and the point at which they discovered that there is this dementia matter in their lives becomes just a trauma. So we need to try and find a middle ground where we have a reasonable expectation of our health and care system, and that people know where to go to and what to expect and how to look after themselves during that period of time.
Andy, that was great. You didn't need any prep for that. That was absolutely great. Thank you. And also thank you for emphasising both the personal, the emotional and the compassion issues, but also the integrated system approach, which is great. So thank you for that. Stuart, all yours.
Thank you, Chair, and thank you, Gail and Jay. And just reading back through this again, kind of a couple of reflections from me. I think it's great to see in the appendix the focus on the impact of particular protected characteristics. I wonder whether we want to be braver and actually, I appreciate it may not be into this now, but how it gets actually into the main strategy. Appendixes always worry me. And we've talked about how we embed our approach to health inequalities into everything we do. So I think when we develop the action plan, I'd really like to challenge about how that will be seen through every part of that, because we know that certain communities and responses to that may differ. So I think both from a metrics perspective and a lived experience about how that is built through that action plan. And then the second one is necessarily that we built it around the NHSE framework, and I think that's really clear. But I think there may be a missed opportunity here, and something we can pick up in the future, that actually there are other things around people's lives with dementia that will help to make their lives easier. And some of that is about the built environment. Some of that is around design in buildings. And I know maybe 5-10 years ago, we did a lot of work around certain colours of floors within certain settings. There's maybe a question yet about actually, if we want to take this further at some point, about how we look about the wider environment, the community, but also about around people's lives. It makes it easier to live with dementia more sustainably as well. But I think the first point, definitely, I'd really like to challenge and see if we can help with that around how the inequalities aspect is built into that action plan would be a key priority for me.
That's great, Stuart. All great points. Gail and Jason, would you? I saw you nodding as Stuart was speaking. Is there something you can pick up with Stuart outside the meeting as part of the future?
Yeah, and I think that they're both really valid points. And as part of all the papers I've written, I've done a lot of work in the community, but there's not enough. So we want to make sure that we really continue that focus on our people with protected characteristics. And there are a lot of protected characteristics, so that will be built into the action plan. So there's a lot of things that are in the strategy. Strategy is just words, but the action plan is the doing bit. And with regard to environments and various things like that, that's built into living well and supporting well. So they're part of those. That's already happening in the community. So it's about looking at what's working well as well in the community and actually sharing that information. So that's all been thought about. It's just there's only so much I can put in a strategy, and believe me, it was bigger than this before I started. So I have culled it quite a lot. So thank you, Stuart. That'd be really helpful.
Thanks. Thank you, Gail. Nicola.
Thank you, Gail and Jason. Thank you, Gail, for coming to West Suffolk Foundation Trust Board to discuss this strategy and its production. So that was great. And I raised this issue then, and I see that there is mention of the resource issue, and I've heard that today. This is a rightly ambitious strategy, and we've also heard that there is a significant gap between people's experiences now and what they need to be in the future. And that does have to be resourced. So even thinking we can start by kind of earlier diagnosis, there's a resource implication of that in terms of the diagnosis and then the care that's available afterwards. So I suppose my challenge to us all is how can we, it's right to support this strategy, but how can we do that without an identified funding stream? Are we setting ourselves up to fail with this, or how much of a priority is this for us as a system?
Thank you for that. And Jason, I'll bring you in at the moment, but let me just suggest, unless you think this is a bad idea, with the discussion that's been in the chat as well, and the points that have been raised over funding and long-term sustainability, as an ICP, colleagues, you may think that this is a right and proper question to ask of the ICB. And of course, as ICB chair, I realise I'm, got in both seats there, but this is ICP business today. So if the partnership wants to directly ask that question, long-term sustainability, October 24 onwards of the ICB, that's perfectly right and proper. I saw you nodding, Nicholas, so thank you for that. But Jason, over to you.
Yeah, I just want to come back to the point. I think you're right, Nicola, in what you're saying in terms of the funding gap. I think what we have seen over the last 2 years and what Gail has managed to imbue in terms of the culture is where we can work smarter together. So we've already discovered, as we've walked along this path of developing the strategy, places where we weren't really connecting. So if you think of older people's mental health services and dementia, when you look at the teams that work out of Ipswich Hospital in terms of discharge with REACT and how they work with dementia intensive support teams. So there's parts of our system that kind of separate between mental health and physical health, and dementia, as Andy kind of points out, sometimes gets caught in that gap between physical health and mental health. I've been really excited at what we've seen and what Gail has kind of developed and the conversations she's brought forward and how people have responded to that in teams. So at the moment we've got a really good example of working within Ipswich and East Alliance and how the DIS team can work with REACT. And some of that will be about resource, but some of it will just be about how teams work smarter together and share information and advice and support one another. So there are some things we can do without huge amounts of funding, notwithstanding that, a question probably will be asked to the ICB and to the County Council about, the numbers increasing and obviously the prevalence increasing as well. So, but there are some real bright sparks of community integration that actually we're seeing the benefits already. So just to give you some confidence in that.
Great, thanks. And let's take it as an action to look forward to ask the right questions about that long-term sustainability for partners. Thank you. So, colleagues, just conscious of time as well, we've received a great report, which we're all very enthused about, and thank you to colleagues for all the work that's been done. We're asked to support approve the strategy and actually support the oversight and delivery and the further co-production that's going to be required and integration between colleagues. Are we happy with the additional comments made today to support and approve? Everybody comfortable? That's good. Right, now we're 15 minutes behind. So we do need to accelerate. The items, however, have been substantial and very important, but let's keep going as fast as we can. Suffolk Community Foundation Strategic Plan 23-28, Melanie. All yours.
Thank you very much, Will, and it's great to have this opportunity sandwiched in and amongst these very important, significant items for our community to have the chance to present the strategy for the Community Foundation. And we're one of the 3,000 voluntary sector organisations working in Suffolk. I'm not sure what the Essex figure is, but I'm sure someone can put it in the chat in North East Essex. But a huge network of voluntary sector organisations that are working in the same communities with people who have poor dental health and who are living with dementia. So it is relevant that we consider all of our work together because we're all working with the same people, and it's great to have this opportunity. Suffolk Community Foundation is one of 47 community foundations in the UK, and we're coming up for our 20th birthday. So it's right that we, after 20 years, reflect on where we've come from and actually what we need to do in the next 20 years, which is where the strategy has come about. And those 20 years saw a really rapid period of growth we started off with a £1 million seed fund. Thank you, Suffolk County Council. That came about because we were the third last community foundation in the whole country to get going. You may not be surprised that Essex got going way earlier than we did. And one of the reasons we got going so late was because there was a view in Suffolk that there wasn't a need, that there wasn't a level of deprivation that warranted having a community foundation, which is just unimaginable now. And so we've grown from that £1 million seed to an endowment of over 21 million, but more importantly than the endowment is giving out around £5 million worth of grants to voluntary sector and community groups every year. That's significant, and the strategy aims at increasing the impact that we can make on communities in Suffolk through working with charities and community groups. That's our goal, and that's what we're planning to do. The strategy has come about by I guess a year and a half since I joined the organisation of listening hard to colleagues about their experiences with the Community Foundation and also what they need to continue their work and do more work with the voluntary sector. It's been a very fluid, unstructured engagement period, but it's been very much listening to voluntary sector, to the NHS colleagues, to local authorities, to local businesses, and to education institutions and clinicians in a kind of fluid, evolving way. So that's how we've developed that. And we're trying to align our strategy with the strategic priorities of other organisations. So, for example, when I met Rachel Kearton from Suffolk Constabulary for the first time, and Rachel told me that a third of all police activity is responding to incidents relating to domestic abuse, I questioned, are we making a third of our grants to organisations that work to support people living with domestic abuse? And we're not. And should we be? So we have been asking these questions about how we prioritise our work. So I wonder, I think Kathy might be able to just share some of my slides for me, please. I'm not going to go through all of them, but I just wanted to pick out some of the key points. Thank you. So to pause on this one, this is very important. This is symbolic for us. And Suffolk Community Foundation, this came about one of my colleagues, Karen Moy, was sat outside her co-op one night and in Thurston, where she lives, and looked up at the sign, which was Thurston's co-op. And we reflected, actually, this is what we want the Community Foundation to be. The Community Foundation for Suffolk. It's Suffolk's Community Foundation. This is your Community Foundation. And so the apostrophe S is very important to us. And as I think symbolises the shift. We want to be a community foundation for everyone, to be relevant and to be more accessible. So if you just maybe flick on a couple of points, a couple of slides. So the priorities, our priorities here are areas of focus. Where do we target this additional money that we can bring into the county? And we have landed on 4 key areas listed there. Domestic abuse is within equality and inequality. Environmental and climate change is a new area for the Community Foundation to focus on and has created a lot of discussion, but is very relevant both for the county that we live in and clearly to contribute to the global challenge around climate change and our environment. So if you could maybe just go on the next slide, please. I won't go through these, but basically some of the points on these slides are that we are trying to increase the finances that we bring in, and this can supplement and make a really significant impact. Many of the organisations that we work with, some need a lot of funding, some need a very small amount to make a very big impact. Even £500 can make the difference, and they're run with volunteers. So we are diversifying our income streams from maybe our roots, which, like all community foundations, the roots started off with the landowners of the county, and again being more accessible and relevant to everybody, diversifying where we get income from. Those landowners are still very important, but we also work with local businesses and younger philanthropists. And the role of philanthropy, I think, now is needed even more than ever, as the state sector, what's available on the public sector and how communities can be supported by the public sector, it's changing. And so the role of philanthropy to step in and make a difference, I think, is really important right now. So to move on to the next, please. And so just to finish on this one, so this summarises our strategic aims for the next 5 years. To diversify our income streams, we are planning to bring in more money into the county, to deepen our knowledge with communities, and the knowledge of the charitable sector using information that already exists, sources like the JSNA, for example, working with the university and the Suffolk Observatory of Data and Analytics, but fundamentally to have the greatest impact on communities through our grant making. The strategy will be clearly under review. I mean, it's important that we work with colleagues on this, and I'd be really happy to come and chat to and others around this and what it means to you. I've also included a couple of slides at the end around something which is a very new area for us, around Sizewell C. So at the beginning of this calendar year, Suffolk Community Foundation received the first annual payment of just over 2 million of a community fund that we are managing on behalf of Sizewell C. And this will be, again, it's a good example of additional income being brought into the county, 23 million over 10 years. We are an apolitical organisation. We do not have a corporate view around nuclear power or the construction in Leiston. However, there will be, if the construction goes ahead, we felt we were best placed to manage the community fund. The community fund is going to be allocated to East Suffolk, the East Suffolk Council area, and that's where the grant making will be. We expect the grants to probably start from around the summer, mid-late summertime, and they'll be administered by an awards panel that will oversee the distribution of funding, which is to mitigate the impact of the construction and have a positive impact on the economic, environmental well-being of people in East Suffolk. And the slide here just sets out, as specified in our legal agreement with Sizewell C, the makeup of the awards panel, who will meet 4 times a year, to be chaired by a trustee from Suffolk Community Foundation, and we will give out grants. This is exciting for the voluntary sector. There's no limit on the size of grant making, and there are no stipulations around multi-year funding. This, we know, is one of the big concerns of the voluntary sector, actually needing more guarantees around funding, needing multi-year agreements, and I hope that this might be a way for us to do that. I'd like to draw your attention to the 4 independent members. We will be inviting applications for 4 independent members to join the panel, and we'll put details around who we're inviting on our, or what the criteria is for those roles, on our Suffolk Community Foundation website, where there'll be a dedicated page for Sizewell C Community Fund. What this means, though, for areas that are outside of East Suffolk, Ipswich, where there's just such a significant need, and West Suffolk, where we as an organisation have are planning to make a greater impact, because most of our grant making traditionally has been in Ipswich and East Suffolk, so we are deliberately targeting West Suffolk. And what this means is that even though we will have the community fund, which can only be spent in East Suffolk, we will use our other funding streams and divert those into West Suffolk and Ipswich as far as possible, where we might previously have made grants in the East. So, yeah, I think that was all I was going to say. Thank you.
Melanie, thank you very much. And Melanie, would it also be fair to say that you presented to the chairs group earlier this week, and actually there was resounding support for your strategy and plans and your logic train, the way you're doing things. So great support from the chairs group also. Colleagues, any questions for Melanie? The request today is that we support the strategy, and of course there are some things that Melanie's flagged there for you to keep your eye on and look forward to future engagement in. Is everybody content? Fiona.
Thanks, Will. Just a quick one. I know you're trying to catch up some time. Thank you, Melanie, for that. And I think, just to say that the sector broadly and colleagues I've spoken to have really welcomed a new way of looking at things, and the consultation and genuine and transparent conversations that have been taking place across the sector to inform the strategy. So thank you and your team, and we're looking forward to a successful continued working relationship.
Thanks for saying that, Fiona. I know that's appreciated, so thank you very much, and well done, Melanie and team. Okay, so with those comments and thoughts, are we happy to support? And agreed. Thank you, Melanie, and good luck. We look forward to hearing some great outcomes over the years to come. So, moving on to the next item before a break, My Health, Our Future, the latest research on health and wellbeing for young people. Luke, I think I'm coming to you for this. I'm just conscious of time. If we could do this in 10 minutes max, presentation of 5 minutes questions, I think that would help us all. So, Luke, all yours.
Okay, thank you, Chair. To cut down my presentation to 5 minutes is quite an ask. Perhaps if I could ask.
No, you can do
the members.
10, Luke. You can do 10 because it's a great piece of work.
Thank you. Well, perhaps if I could ask the members kindly, really as a result of the presentation today, my main objective is that I would love to have a further conversation with you if you're interested in this work. So maybe if we could move the discussion for you to contact us following the presentation, that would be fantastic. I'm a Research and Business Development Officer at Health West Suffolk. I'm here today to talk about My Health, Our Future, our programme looking at children and young people's mental health and wellbeing. It's an online survey completed with schools and colleges for young people aged 11 to 19 or 25 with special education needs and disabilities. We received over 13,000 responses in the 2023 school year. I'm going to cover a lot of topics today, from mental health, physical health, healthy lifestyle, sexual health. But as I said, what I really want you to be thinking about is how the evidence from the MHOF programme can support your collective ambition for everyone in SNE to live well. So if you have an interest in the work, please do go away and have a look at the publications. And if you can use the findings to have an impact in your work, we'd love to hear from you. So who we heard from as part of My Health, Our Future? Most of the young people we hear from are years 7, 8 and 9, although we also get good buy-in from colleges in Suffolk. I won't go through the demographic details, but to say that it's representative of our diverse community in Suffolk. When we talk about the data, often people want to know what the trends are in wellbeing for Suffolk and how we compare to the UK overall. So we use the short work everywhere emotional wellbeing scale to gauge overall wellbeing. We've seen a decrease in those scores following the pandemic. Although scores increased in 2023, we still remain in Suffolk lower than comparable national averages for wellbeing. We also include the Good Childhood Index, which measures young people's happiness in relation to 10 aspects of their lives. So you can see that on the chart here. Scores below the midpoint on the 0 to 10 scale in each of the domains are considered to have low well-being. So that's the pink bars that you can see. As you can see here, the areas that young people say they're most often unhappy with were school, their appearance, their future, and the way they use their time. Young people with additional support needs, LGBTQ young people, were more likely to report being unhappy on all aspects of their lives that this scale measures in comparison to their peers. Young people who said that they were unhappy with their school were also 5 times more likely to report low well-being overall than their peers. So we asked young people directly what they think would be helpful for their school or college to do. So some of the most popular things young people told us they wanted to see in school were more awareness of mental health among staff and students, more information about support options and where to access them, having access to counselling or someone to talk to, and having more time to discuss mental health. Furthermore, we know from multiple years of MHOF that students who feel that they have someone to talk to in school or college are less likely to report low well-being and less likely to suffer moderate to severe anxiety.
We also asked young people for the first time this year about the cost of living. Results showed that around a quarter were either worried or very worried about the cost of living, mostly about missing out on social activities or not being able to go on school trips. Also, there's hundreds of young people in our survey this year who were worried about not being able to afford equipment or hygiene products. This year was also the first time that we asked about healthy lifestyles. Firstly, we asked students if they were concerned about their weight. So around a quarter of students said that they were concerned that they were overweight. 8% said they were concerned they were underweight. Female students, LGBTQ students, and those with additional needs were most likely to be concerned about their weight, as were students with low well-being or who were at risk of anxiety. We asked young people what could support them to manage their weight. Most of those responses come down to more information, but also improved access to sporting facilities. Related to healthy lifestyles, we also collected data for the first time this year about the prevalence of smoking and vaping. So 12% of young people who answered this question said that they currently vape. I thought it was really worrying to see that of those who currently vape, just under half said that they'd never been a smoker. Around 5% of young people in Suffolk told us that they currently smoke. Again, based in co-production with young people, colleges and community partners, we've added quite a few questions to the survey this year about relationships and sex education. One of the key questions we asked was whether young people had heard of iCash, which is one of the main sexual health services for Suffolk. Only 17% of students in Year 9 and above said that they were aware of the iCash service, suggesting that information for young people about where to access sexual health services could be improved. In addition, in response to a 2021 report by Ofsted on sexual harassment in schools, we asked students in Year 9 above if they'd seen or heard any of the following forms of sexual harassment in their school or college. Almost 5,000 young people reported that they'd seen or heard at least one form of sexual harassment in school. This included over half witnessing sexual jokes and the use of homophobic language, as well as 30% who'd witnessed unwanted sexual messages or the sharing of videos and pictures of students of a sexual nature. We think this is a really important issue to talk about, so we've worked in co-production with Survivors in Transition this year. Thank you very much, Fiona, to gather more information about this topic and survey in the upcoming year. So the next steps for My Health, Our Future. The next year of the survey, MHOF 8, is live now with over 1,000 responses from 6 schools and colleges. We have specific reports coming on LGBTQ young people, SEND young people, which I think has just become available today, sexual harassment and ethnicity. Then I'll ask for you is to consider how you can do things differently as a result of the evidence provided by so many young people in the MHOF survey. The ICB commissions this as a resource for Suffolk, so if you're able to use it to influence commissioning, service delivery, to support your plans for tackling any of the issues raised, we'd really love to hear from you. If the data can have an impact in what you do, please do get in touch. I'll put my email in the chat. We might be able to support you to use the data to have impact for young people, or if there are particular areas the survey could support you with in the future, then we'd be happy to hear from you. I've gone through that as quick as I can. It's up to you, Chair. I'm happy to take some questions, or if you'd prefer, if anyone would like to have a more detailed discussion, then please do get in touch.
Okay, thank you very much, Luca. Will's lost his signal, so he's just asked me to take over. But thank you for that, and thank you for going through that so quickly. I think we do need to take time for a couple of questions. So we've got a couple of hands up already. I'll go to Nikki first.
Thank you. Well done, Luke. Very impressive response, I've got to say. So I just wanted to come back to I just wanted to come back to the demographics.
Yes.
So you talk about 73% white British, 5% white other, and 3% Polish. That's 81%. What about the other 19%? Our communities are becoming more ethnically diverse, and there's no reference to children and young people from Black, Asian, and mixed heritage backgrounds, which potentially could be the other 19%. I know that you've just said at the end that there will be a report on ethnicity, but I think that there has to be a lens here as well. it just feels like a missed opportunity if we don't include that as part of this, given the inequalities and the experience of young people from Black, Asian and mixed heritage backgrounds. And they are overrepresented in the youth justice system. We have more children in care from those backgrounds. We have people subject to child protection plans and child in need. So there is a disproportionality issue that we need to think about as well. The only reference I could find when I went through the document was on vaping on page 17. So great work, but for me, it's a bit of a missed opportunity if we can't go back and look at ethnicity as part of the overall report. Thanks.
Absolutely. I think that young people from diverse communities are actually overrepresented in our data compared to what's available, certainly on Suffolk Observatory, the census. So, as you say, we've got a more detailed report on ethnicity forthcoming. I think I find actually, to be really transparent, that even with 13,000 young people, sometimes the numbers of young people from a specific ethnic background that you might hear from can be quite small.
That kind of leads to questions about, well, which of the results are valid, which aren't. So that's the reason for doing that more detailed piece of work to release a report specifically on ethnicity, which is forthcoming. So hopefully, Nikki, once that's available, that would address that issue. There is also information about some of the variables we collect in relation to ethnicity in our previous reports as well. It's just that we've taken that slightly different style of reporting this year to be able to focus on it more.
Okay. Thank you, Luke. I'm going to take a couple of other brief points. I've got Fiona and then Andrew.
Thanks all. Thanks, Luke and the team, I think, for taking the really brave move in terms of asking young people about sexual harassment they're experiencing in schools. And I say brave move because I feel like it's something we've been avoiding as a system for a couple of years. We've got loads of national data, and since the Everyone's Invited scandal in 2020 and the subsequent Ofsted report, I feel like I've been banging a massive drum but haven't had any local data. So now I have some local data to shove in front of people as well. And part of me wishes we hadn't had to rush through it so quickly because, and I would encourage colleagues on this call to go back and look at the sexual harassment stuff because it's staggering, quite frankly. The fact that over 2,000 young people of only a particular cohort that we asked the sexual harassment questions have experienced some form of sexual harassment in school and with their peers is shocking. And as a system, we need to take note and we need to do something about it. Sexual violence is rife amongst young people in schools, peer-on-peer sexual abuse and sexual violence. We've certainly never had as many cases of young people coming forward to get support, and we've got to respond to this. We now have some local data, so I hope this conversation or a piece of research that's not just going to sit on the shelf. I hope we're going to build some actions around this pretty urgently as a system now that we have some local data.
Yeah, thank you very much. Just to say that introducing the research today, we do need lots of different places where we discuss this. I've also invited Luke and Lisa to our Uncomfortable Truths event to talk about some of the specifics as well. So I think we'll be coming back to this. And then to Andrew.
It's just a request that in the future we think about using this really powerful data of what people expect. We can compare it against what the evidence says actually works. Because I wonder there's a mismatch between people's expectations and actually what the evidence says. And that might help influence public health interventions and education interventions. There's a real opportunity there to understand misperceptions and to not correct them, but to work with them to get people the outcomes they need.
Okay, thank you. Andrew, can I just take one last quick point from Ruth and then we're going to close?
Oh, yeah, Luke, thank you very much. A really valuable piece of work. I agree we need to take it forward. As the parent of 3 teenagers at secondary school, I can a lot of what you're describing, chimes really loud with me, in particular the sexual violence and actually the low level stuff, the toxic behaviour, the amount of vaping in toilets and things like that. It's just, you know, it is potentially a big issue. These kids have gone through COVID. They've gone through different experiences, and some of their interrelationships are not great. There's a lot of work being done, and I know the schools are under a lot of pressure in a lot of different ways. And the psychologists in schools and other surrounding supports are really trying their best. But I think we've got a real duty for our young people, our future adults, and our area to do as well as we can in this.
Okay, thank you. Luke,
Thanks, everyone.
An offer to come back to people to talk further about the research in different ways and different forums. So do you want to just underline that again?
Please, if you can use the data to influence conversations, if it has an impact on you, if it changes your thinking, if it allows you to do things differently, we really want to hear about that. We're happy to support you to interpret the data, to use the data in a way that benefits your service and young people. So yeah, please do get in touch. It's an ongoing conversation rather than a one-time sharing of information, I think.
Thank you very much.
Thank you.
Thank you. So Will is back on the screen, but I think he's still having a few problems with his Wi-Fi. So what I'm going to do is we have ended up running slightly behind because we took the extra time for the dental item. Welcome to Bev and Ben from Connell Farrer and Close. What I'm going to suggest we do is just take a very quick break and come back at 12 minutes past 11. And we're going to hear those two presentations around Left Shift and then hopefully have time for discussion. So mic's off, camera's off, and we'll be back in just a few minutes' time. Thank you. Okay, I can see people beginning to come back now. Hopefully you managed to at least boil the kettle in the time allowed. So apologies again for overrunning. I can see that Will might still be struggling a bit with the signal. Welcome, Ed. You did manage to make it on time.
Absolutely late, yeah.
Fashionably late. So we're now going to move the meeting on to a slightly different kind of tempo, and I'm just going to introduce this item. At the last meeting of the ICP, which was in December, you'll remember that Ed and I brought a very short paper to the meeting to propose that we begin to kind of integrate the concept of a left shift into our ICS integrated care strategy. So I'm not going to go back over the kind of left shift concept again. I think most people have seen that. But whilst we agreed that we should integrate the kind of relatively simple concept of a left shift into our strategy, what we also agreed was that the complexity of actually achieving that would be something which would take much more detailed sort of discussion across partners in the ICS. So as part of that, what we're aiming to do is to try and make some time on our ICP agendas over the next few meetings to explore left shift from a number of different perspectives. And so this morning we've got two papers which I think will prompt discussion. So what we're aiming to do is to go through both papers, one after the other, and then have some time for discussion. The first is a paper which is from Alex Royan, is from our knowledge and intelligence team for Suffolk and North East Essex, and then two colleagues, Bev Evans and Ben Richardson, have very kindly joined us from Carlisle Thorough. So what I'd like to suggest is that time is at a premium for us, and we do want discussion, is that, as I said, we just do Alex's paper and then Bev and Ben's. Please do put questions, comments into the chat. I think the chat is helpful as we go through. I know Alex said he was going for trying to answer some of those in the chat if you've got queries about his presentation. And then what I'd like to do, Alex, Bev and Ben, is to try and get through these by about sort of 20 minutes, so we've got proper time for discussion from the group. And I've no doubt at all that once people have heard what you have to say, they'll want to talk about it. So I'm going to hand over to Alex, first of all.
Thanks, Susanna. Hopefully you can now see my slides. Yeah. Good morning, everyone. I'm Alex Rowan, I'm Deputy Director for Strategic Analytics, and I lead the Suffolk North East Essex intelligence function, which is an analytical collaborative that aims to provide the system with insights, particularly of strategic interest. And I'm going to briefly rattle through some of the kind of key findings from a book project that we undertook last year to look at the demand capacity that we might require across the system over the next 10 years. What this project essentially tried to do was kind of put forward a proposal as an analytical kind of baseline for what kind of demand for the healthcare might look like over the next 10 years. In itself, it doesn't really kind of propose any solutions, but what it probably does is start to provoke some kind of interesting conversation around what kind of configuration of the integrated care system might need to look like over the next 10 years to try and find the most kind of efficient and good quality means of delivering the necessary care for the population. I'm really just going to rattle through this over the next sort of 10 minutes and I'll open up for discussion really, but the context, and this is context for probably any ICS right now,
is that we will have an increasing population and we will have an older population. So through to 2032, about an 8% increase in the population, an extra 75,000 people, of which about 33,000 might be over the age of 80 years old. So that's an increase of over half in the size of the population aged over 80. What we're also projecting is that whilst people may be expected to live longer, they're not necessarily being expected to live longer in good health. So the age at which people start to develop major illness could well remain constant. And if that's indeed the case, that means a greater proportion of our population will be living with long-term conditions, and the prevalence of multi-morbidity will increase. And there's been some quite interesting modelling done, particularly by some of the national think tanks like the Health Foundation, who have shown that when you look at the kind of future projections of prevalence of long-term conditions, the greatest increases in some of those conditions, which you would expect to see managed principally within primary care in the first instance. So that's the kind of context to the kind of demand capacity project. And what we tried to do was develop a system view of demand capacity for SNE ICS. Now, we didn't look at the entirety of the system. We focused on general practice, both acute community trusts and also adult social care. And there were aspects of that were currently out of scope. And this is part of an ongoing programme of work, with the next phase of this now starting to look at the link between health of the population today and what that means for demand and activity for services and cost of those services, and how population health is going to change over time, and therefore what services may need to change over time. And we did these projections over kind of a number of scenarios, from a sort of do-nothing kind of naive forecasting approach through to starting to impact the various kind of more realistic assumptions based on known programs of change, but also in some cases much more radical options for change. So what we did, and this is a rather complicated picture, but it's kind of trying to depict the way that we did the modelling. And the starting point for this really was to kind of start with general practice and look at demand for GP appointments. And what we did is look at historical activity, come up with an estimate of what we think unmet demand for GP appointments is, which range from about 7 to 15% of on-the-day activity, depending on where we are in the ICS and the lack of kind of GPs per capita in some areas. What we also did was then factor in growth and complexity of care needs due to kind of growing multimorbidity. And then we also factored in kind of how demand for appointments may need to grow as the kind of population increases. So the kind of demographic growth in addition to the non-demographic growth. And that was the sort of foundation for the whole of the modelling. And essentially the appointments then generates referrals into acute. And acute, of course, you also have demand for urgent care, which is projected at around about 2.5% per annum increase. And then on the kind of more social care side of things, what we also did was start to build in projections of how we expect the number of people in the population to be, how we expect the proportion of those growing who are living with long-term conditions, and the number of people who might need to receive help at home or in residential care. And that generates this kind of consistent system view with consistent assumptions running through the whole piece. In terms of some of the findings, one of the kind of like key kind of headline messages really was the growth that could be required, particularly in the sort of GP workforce. So when we look at kind of the current level of unmet demand, and that's obviously a very difficult thing to put a number on, but we kind of came up with this estimate of around about a shortfall of 70 full-time equivalent GPs today. And then when you then start to factor in what it would take to kind of shift to more sustainable workloads on a daily basis, and then start to factor in that demographic, non-demographic growth, that number could grow quite unsustainably to almost 200 GPs across the ICS in 10 years' time. So quite a significant increase that would be required, particularly in the context of the challenges around we've had with growing that workforce. The acute modelling is much more complicated, and that's because we were trying to ask a lot more sophisticated questions and really just put in place the kind of analytical infrastructure, if you like, for us to be able to support complex questions around what if we kind of grow demand in one area, what does that mean for supply in other parts of the hospital system? So we developed this kind of simulation modelling approach, and that enabled us to kind of measure how growth in things like waiting lists, as well as growth in the kind of demand for activity as well, because it's a complex dynamic. And what we found is that in an unmitigated scenario, which is not really a realistic scenario because no one stays stationary for 10 years, waiting lists would grow, as you'd expect, very significantly as demand for emergency care and the proportion of beds occupied through emergency admissions grows. That really constrains elective capacity. But when we start to factor in some of the planned programmes of change that we have, both across Essex and West Suffolk, not least the establishment of the whole new hospital at West Suffolk, that waiting list growth could be stemmed quite significantly. And I'm really quite reluctant to put a number on waiting list growth because it's such a complicated thing to model, but we still model the growth of at least a kind of a third on waiting lists over the next 10 years. In terms of community healthcare, we focus principally on North East Essex as a starting point for this. And what we found was that as demand would grow from referrals out to general practice and acute, assuming that future levels of demand are met in those sectors, we did quite quickly start to see quite a significant shortfall in the ratio of referrals and discharges, up to around about 2,000 on average per annum. And you can really see that play out through kind of constraints in the workforce, particularly district nursing and physiotherapy services, in part because of the nature of and the way in which some of those services are being delivered. So the kind of workforce challenge really plays out there. And then finally, with adult social care, we looked at this from both a community social care perspective, so domiciliary care and other community-based services, as well as residential care. And what we found is that on a do-nothing basis, which is really just what we're seeing now, project that forward, we still get this growth of almost 60% over 10 years. But if you were to then start to account for a reasonable increase in the amount of activity through acute services in particular, we might actually see that growth being much higher, up to around about 80% over 10 years. Demand for residential care is a bit more stable, but still projecting increases. In terms of just kind of strategic implications, and this is really just an opener for discussion rather than a kind of any sort of proposal. But I think what we found with the kind of GP modelling is that I think that quite clearly articulates the unsustainability of the GP workload, and therefore this kind of real need to put kind of general practice on a sustainable footing. And given that projected growth in things like multimorbidity, what does that tell us about that kind of need for this integrated primary care model with the kind of more holistic approach to managing long-term conditions? I think that also tells us a bit about that kind of need to try and put communities in a more kind of increase the resilience amongst communities, and really kind of expand on those options for kind of more home-based or community-based care, including that kind of approach to how we address kind of multimorbidity as this growing challenge. We talked a bit about the kind of growth in the kind of emergency care requirement and how that constrained capacity for elective care. And again, it just tells us about kind of what are the kind of key options around sort of demand management through proactive and preventative care. And the key questions, I guess, are around, well, what does that need to look like and how much of that do you need to do to actually have an impact within these timeframes? But I think it also poses questions around, are there ways that, from a strategic perspective, we can be more systematic with these sort of approaches and really embedding kind of proactive and preventative care through the kind of live well domains in particular. It also tells us, I think, a bit around how it's not necessarily the case that our plans are wrong. They're probably the right plans, the right priorities, and our modelling kind of articulates that to some degree. But it really shows that there's a need to execute those plans and kind of deliver on those targets that we're setting. And by doing that in a way that continues to diversify the approach and kind of really leverage the strength that integrated care offers, working collaboratively, vertically and horizontally. And then I think probably one of the final points is just that there is a requirement for capacity to grow here realistically in order to meet demand. Not necessarily as configured now, but almost certainly grow somewhat universally. And I guess there's a real question for, particularly, at an ICS level, how do we embed kind of good health economic thinking into kind of designing the right balanced approach of resource across the sector, such that we're really getting the right kind of allocation of resources in the most economical way, triangulating demand, finance and workforce. And then final point is, all of this tells us just about that need to put in place this enabling environment to make sure we've got really good strategic oversight of all of the key enablers of integrated care. And yeah, just to say that this is the product of a significant collaboration of a large number of people across the ICS. So my gratitude to everyone who was involved in this. And I'll pass back to the chair.
Thank you very much. I know a couple of colleagues got hands up, and we predicted that. But what we thought we would do is to hear from Bev and Ben from Carnal Farah, and then begin the discussion, if that's all right, because I suspect that if we don't do that, we're going to get distracted by discussion straight away, and we won't have time to hear from both. So if that's all right, Ruth, and I think Zeph, can I just hold you for the minute, and we'll hear from Bev and Ben, and then we will have time for discussion. Okay, so I think I'm handing over to you, Bev.
Yeah, and I've put slides on screen. Can you see them?
Can indeed, thank you.
Super. Hi, I'm Ben Richardson, Managing Partner at CF, and I'm joined by Bev. I was going to do the first set of slides, we'll quickly whiz through them, and Bev will close it for us. Yep. We were going to talk about 4 topics. One is about the wider impact from recent research that we've published with CONFED of the impact of investment in primary and community care. Second is talk about real-world evidence of what's actually been observed. Third is to share some analysis of what we think will happen in the population if investment isn't made. And then a fourth one is a really more forensic look at costs and how to take them out. So on the first one, I won't do all the slides, but conceptually what we want to talk about is that the need for investing in primary care and community care has a logical flow through it. That if you invest in primary care, here it says more GPs. It's not just GPs. Just noticing the point made earlier about the growth in it is primary care capacity, and that can improve health and reduce emergency admissions. Investing in community care can increase community staff and improve the community offer and reduce the risk of hospitalization or rehospitalization. And that contributes to reducing AD, inpatient spells, occupied bed days. We've done quite a bit of analysis and demonstrated that there was a 14 times return on investment in the economy from investing in primary care and community care, which was greater than any other segment of care. We also used patient-level data linked together to be able to show that the areas with the highest level of community contacts per capita had the lowest levels of occupied bed days per 1,000 population over 65. So a quarter of the elective bed days and half of the non-elective bed days for those places that had higher levels of community support than others. And we then have taken a quick summary of some of the work that we've been associated with in the past to see what happens in the real world. That was all based on, that was data science modeling with real data, observational. It wasn't theoretical, just to make that point. But what happened in real life, this looked at the following impact in Tower Hamlets and in northwest London over time of the impact of systematic programs around integrated care, local care, whatever you call it, similar to the sorts of things that we're talking about here in Left Shift or whatever else you want to call it, Susanna's model. What it shows is, in particular, let's see if I can use this. This line here is what happened to non-elective admissions in Tower Hamlets in a 5-year period following on from when they did some really transformational work, which is dramatically dropped and a level that the rest of the country was going sideways. We didn't see that decline. In northwest London, where similar sort of program was pursued, 3 areas that pursued it vigorously, which were sort of the inner 3, saw similarly a steady dramatic decline when the other outer boroughs didn't see any impact. Now, what was that? Well, probably the best illustration of it is from
Tower Hamlets, where there was a clinical model that segmented the population and thought about intensity, this is of diabetes, and considered social determinants. It made a deliberate investment in additional workforce, which saw more capacity in primary care, no new GPs, but additional capacity in primary care. It organized it into networks. It had organizational development to support that, and it created one of the first integrated data sets in the country being used for population health management. In fact, Northwest London did the same thing, and it remains the largest and best integrated data set in the country that's been used by most by more than 15 years now. Some common points to pull out from this and others were that if setting out to do that, the impact aspiration needs to be high. 20% impact is an example of what mean in reducing acute demand. There are choices to make about where you focus, often frail and chronic conditions, and it's essential that it cover the out-of-hospital care. Understanding population needs is a critical element, and then being able to design, that you use that to be able to target the high-cost patients. That is nakedly what population health management is about. And the sorts of delivery model it involves are targeted interventions at named individuals to change the pattern of care they receive with proactive care, effective discharge, multidisciplinary team working, critical to enable with information and workflow, and also payment, and critical to involve system working. So those are some observations of what's happened in the real world. We've done some work in Manchester, which has a rich data environment, and we use that data environment to try to quantify opportunities to improve health. We pulled together all the different elements, and I believe that you now in SNE have similar elements available. We had a segmentation into different conditions. We looked at what the concentration of cost and spend were, and what you see is the population in good health, 72% of the population, but only 23% of cost. Those with single long-term conditions, roughly the equivalent, 12% and 11%. Multiple long-term conditions, 7% of population, and more than double that in cost. Mental illness, 5% of the population, and more than triple that in cost. And frailty, to pick it out, a percentage point, but nearly 20% of cost. So highly concentrated, as a picture that you see elsewhere. What we looked at were three opportunities. One is the opportunity to reduce the progression of ill health, to try to prevent what's going to happen otherwise. A second around identifying variation in how patients are cared for and supported, and hence what costs they have. And a third was targeting the most disadvantaged communities. Just to illustrate a couple of those, this is our view of what is going to happen, because not just of aging and inflation, but crucially because of prevalence. So this is the breakdown presented a different way in terms of total costs. There'll be a portion of increasing cost from population growth and a portion from inflation, but far and away the biggest element we expect is going to be from the growth in prevalence of a population that is becoming less healthy, in particular multiple long-term conditions, mental illness and frailty, seeing big increases. And so part of the reason to say that starkly is that not doing this is likely to have a direct cost, that the system is going to become more expensive. We looked at all the costs and how they break down and fall, but what that showed was when you looked at the variation, there were a number of segments of the population that drove where there was the biggest variation and hence opportunity, which included in mental health, in multiple long-term conditions, and in frailty. And so a suggestion that you can really focus not on universally putting this in place, but areas that have the greatest opportunity. And to do so, looked at a set of things that could be done. The ones around preventing the growth and prevalence of ill health are addressing smoking, obesity, diet, etc. The ones in the optimizing the models of care are especially focused on secondary prevention for cardiovascular disease, diabetes, respiratory, mental illness. And then the ones addressing the most disadvantaged communities include the wider determinants of health, which have a strong return on investment. So now, having rattled through that, quickly talk about the view of acute spending.
Thanks very much, Ben, and great to be with you all this morning. So this is based on work that we've done with a number of different systems and different organisations. So as an EG, what you can see in front of you now is from our work in North Central London. This was very much focused on a sort of an 11-step programme to really think about how you're actually going to be able to identify the funding to make this investment into community services and the sort of the outer hospital services. So the shift that you were describing and to respond to the stuff that was presented before this. And that's very much looking at the sort of benchmarking, understanding the current value for money. So where are you spending and what benefits are you getting from that investment currently, to set out a sort of a realistic costing envelope. So understanding between different areas what's right, relevant to the need of that population, and therefore what the benefits are that you would be looking to determine from that, and would drive through in terms of seeing future spend in the acute system being reduced in terms of offsetting the increasing demand. So not about taking money away, but actually looking to see that future spend reduced. That then would focus in on the sort of operational level, and as Ben mentioned, focus on a priority area, e.g. fragile services, and which of those fragile services, looking at the delivery models for those and where they're delivered across, whether it be across the whole ICS or at place. That then determines what the sort of level of funding is that you need. So building up the from the benchmarking and against your assessment of what the need is. So are you spending where the need is, or are you spending in relation to historic patterns that is disproportionate relative to needs and not addressing health inequalities? Thinking then about the overall ICS financial strategy, and so what the position is with regards to that. Then looking at what the recurrent and non-recurrent implications are, so the transition period that you need to move, doing some upfront investment into community, potentially into community infrastructure, as well as actually investing in the revenue side of costs, and then working out the affordability level. So with North Central London as an example, initially the ambition was to basically introduce some of this transformation over a period of 3 years. They actually ended up concluding that it was going to be a 5-year investment time frame, just because of the ability to recruit and also in terms of the affordability side of the equation. That then takes you through to what are going to be prioritised. So you've got a core model of what the services should be outside of the hospital, and which of those do you prioritise first. So, for example, they've done a focus in one particular area around diabetes services, to make sure that there's the framework there to support keeping people out of hospital who have diabetes, either as a long-term condition or as part of multiple long-term conditions. And then looking at what the provider options are for delivery at borough level, so back to the place, implementation side, and then the actual implementation. And this was done very much in conjunction with the acute sector as well as with the ICS and wider partners, so that it was an agreed pathway in terms of transition that the whole of the system was actually bought into. So if we just move on then to our final slide, and then we can open it up for discussion. And you've had this in the papers that you've got, but this just sets out, obviously, in terms of actually being able to, if you're reducing the activity and reducing the spend into the acute side, then obviously provider efficiency also needs to be looked at so that they're reducing their underlying cost base. So that includes looking at the model of care, looking at the workforce, looking at procurement practices, looking at the estate infrastructure and efficiency, and also looking at the back office. And you can see we've set out here some example opportunity areas in terms of having fewer beds open, so that leads ultimately to the potential to close wards, looking at nursing levels, looking at the overall pay and pay bands, looking at the non-pay spend, looking at backlog maintenance, and sort of a focus right across all areas of spend so that you're optimising the reduction of waste and improving efficiency overall. So the combination of those things then enabling you to use growth money in future increases to actually invest into providing this out-of-hospital care and start delivering on that return and addressing some of the challenges that have been presented as part of this and the need for the shift, which is the conversation that you wanted to have. Hope that's been helpful.
Wonderful, thank you. Ben, did you want to come in one more point? No?
No, that's it. Just to sum up that, I hope that gives us a theoretical look at it, some evidence of what's happened historically, a future look, and then a practical one of how you might actually think about doing it.
Okay, thank you. So, unsurprisingly, lots of hands up. We had expected that. What I want to suggest is that we take maybe first 3 points, and then I'll go to Alex and Bev and Ben to see if they've got a short point, and then the next 3 points as well, so bearing in mind the time. So I'm going to go to Zeph first of all. Zeph.
Two really excellent presentations and really make a compelling case for investment in community and using population health management well. I was a bit disappointed, Alex, I'm afraid, on the first presentation because mental health wasn't part of the system model that was described. We had social care, primary care, community care and acute, but mental health not identified as part of the model or in the analysis. I'd be really happy to connect my BI team at EPUB with you and make sure that we can change that going forward. But I think as Ben's presentation demonstrated with the data from Greater Manchester, and indeed actually your own presentation, when you're looking at the conditions with the greatest growth, mental health, including anxiety and depression, people suffering ill mental health are a significant proportion of the cost and the unmet need in the system. So I wondered if we could take forward an action to address that in future modelling. Thank you.
Okay, so that's the first point. That's helpful. So next, Ruth.
Oh, sorry, I'll try and keep it brief. So just being on the system call, there's pressure everywhere, community, primary care, as well as out of hours. So, the hospital trust. So I think we just need to be careful that we've actually got capacity to do this and make sure that people have got whose experience we need actually have the ability to take the time to plan this. And it needs to be designed by those who truly understand it. Suffolk and North East Essex isn't like London. We found this when there's sort of other ways of doing things that actually you can't just go to another community pharmacy if yours is shut. There isn't another one. So and the travel stuff, as we all know, I think we need to get that right. It needs to have clear and robust communications when patients move between organisations in the patient journey. And I think there's some real building blocks along those lines that we really need to be careful that we get right. And some of the stuff there talked about primary care capacity, as you said, doesn't equal more GPs. No, but it does need more supervision, and there is a potential to lose GPs. We've seen that elsewhere in the country, where actually GPs are not being able to get jobs because other things are happening, and there's a real concern there. So one of the measures there was reducing non-elective admissions. I think we need to be really clear as a system what are our measures of success, and that they're not just the knee jerks. That actually we're looking at other things like, are we measuring how many fewer people get diabetes when we do a weight reduction program? I know that's difficult to do, but if we're going to talk about going upstream to do work downstream, we've got to do it properly. Complexity will happen. So there are people, probably me, about to have a heart attack, and there's nothing you can do in prevention to stop that happening. So we cannot stop complexity happening. We cannot stop dying happening. So we need to just be realistic about what the measures are. Just some sneers and proper system working with the people who understand it, not doing to, doing with.
Okay. Thank you, Ruth. All again very useful points. And something I should have mentioned at the beginning is that my team, if you know us well, you'll know we like to write things up. So we are capturing all of this, and we'll produce some written products to help move all of this debate forward. Next I'm going to go to Paul.
Thanks. Ruth, I do hope you don't have a heart attack very soon, and we'll all support you if you did. It kind of follows on from what Ruth was saying. I don't think we need convincing of the case here or the detail of here. There's been a lot of work on this in the system that we're in. There's a lot of local knowledge about it. I think I'm arguing to be guarded against sort of gilding the lily in terms of making the case and the analysis of this, because we all know the case for this. What we need to do is kind of following from what Ruth's saying, find the time and the capacity and galvanise the expertise that we have in the local system that understands the local dynamics, and therefore can point us to solutions. And aligned to that, we need to find a way of having a sensible system-wide conversation about investment, which doesn't quite exist at the moment. A lot of the conversations we talk about growth money here or there, or where there are opportunities to invest, notwithstanding, that's not going to be the whole answer. It's going to be about shifting money from one place to another in order to affect this change. The place for that discussion doesn't exist in our system at the moment, or if it does, I'm not aware of it, and people like me who are involved in delivering these sorts of services are not included in it. So we need to get on with that aspect of it, because we all are convinced of the case for this.
Okay, thank you very much, Paul. Again, good point. So can I just go to Alex Bevan, just very briefly, just ask if there's anything you want to come back on those initial 3 points? Any of you?
I mean, I'll jump in and say I'm conscious that your area is not London. The reason for showing you Tower Hamlets is I do think it is the oldest and best established in the country, and there aren't very many that have actually pursued it at scale. Have done work in Scotland and in Devon and rural Australia, where the physical geography is different, but the concepts are similar. So you definitely need to think through it and design it there. The other thing I think that I detected in the comments is a question of how do you start and where. And I think one thing that's quite different now than given especially the data infrastructure you have is you could start picking off specific areas where you start putting things into place. Secondary prevention of cardiovascular disease, given the worries about the heart attack, let's intervene and address that. How do we identify the known people with high cholesterol that we need to get on lipid lowering therapies, and how do we prosecute that?
Okay, thank you. So we've got some more hands up. I'm going to go to Lucy, then Stuart, and then Nicola. So Lucy.
Thank you. So I did pop it in the chat, but rather unhelpfully as a shout, just saying, it's a bit disappointing that the model seems to start with primary care as opposed to think about prevention and other wider sort of non-medicalised models. This does seem to be quite a medicalised view of the system, and I understand in part that's because it's driven by the data that we currently have in our medicalised model, but we do need to think about how we understand and ascertain the benefits of public health contributions in the prevention space. The other point is I absolutely support what Zeph said about mental health. Not only is it not there as a kind of a disease category in and of itself, but I think it underestimates the comorbidity elements that lots of people with long-term conditions have with regard to their poor mental health as well. I worry that the model slightly undercooks the challenges around children and young people, because they don't tend proportionately to demand a lot of our services now. I think if we don't consider them separately, we may completely undercook the level of investment that's required in order to keep them as a healthy population. So I think there's just something that we would need to stop and reflect on in that regard. The other bit is kind of just been covered by Paul a little, but we know this, don't we? With all due respect, it didn't show us anything new, but what we still haven't done is take those bold steps and make commitments to a greater percentage of the ICB budget being ring-fenced, hard ring-fenced, into prevention, because this highlights where we should be investing. And therefore, we're also going to have to make some equally challenging disinvestment decisions because we recognise there isn't a money tree. So I think there's something about the really clear so what with regard to some of our policies and long-term commitments to funding and decision-making in this space.
Okay, thank you. So I'm going to move on. We'll do another 3 and then go back to Bev and Ben and Alex. So Stuart.
No, thank you. And I think my reflection was that actually we are starting to do some of the bits around the secondary prevention, and as part of through some of the health inequalities most. I think what we need to do to make sure around that is we're evaluating, and Alex's team are involved in how we're going to evaluate that to make impact around that. So I think the reality is that we are doing bits of these works, but I think it's about how we progress. And Ed talked in the chat about sharing that, but then potentially again looking at particular cohorts or areas where we can then start to push that to another level to start incorporating. I think what this feels like is this is one massive big bang, and the reality is we kind of know what we've been said, but also how do we keep pushing the agenda forward step by step as well.
Okay, thank you, Stuart. Nicola.
Thank you. Absolutely fascinating. So thank you, and Bev. I was wondering how Tower Hamlets had fared post-pandemic, post build-up of waiting lists, etc., and the pressures on urgent emergency care and the short-termism, I think, of NHS England in terms of addressing those pressures. So I just wondered about that because the data kind of takes us up to sort of pre-pandemic. I also wondered collectively whether we're limiting ourselves when we talk about community to statutory services, and where we're thinking about investing in kind of community assets and taking that approach. And I also I just wondered how we accept some of the trade-offs, which again links to that sort of short-termism perhaps. How do we accept some of the risks now that will be created by disinvestment, or can we accept those risks now? So I don't expect immediate answers to those questions, but perhaps things to ponder.
Okay, so what we'll do is just pause at that point just to ask Bev and Ben and Alex if they'd like to come back on any of that.
Just a quick one on the Tower Hamlets one. Overall, the thing that's remarkable about Tower Hamlets is that those reforms were put in place between 2006 and 2012. And the impact of it continued to be seen for 5 years following in the data I showed, and more or less it's continued. It made it relatively resilient in the time of COVID. I don't have the data to hand to show that to you, but the thing that it did was it changed the way the system worked, so that they worked really in these networks and they used data to be able to understand things. Now, obviously, things have happened, but that's the main thing I take away as a positive.
Okay, I can see Alex, you've got your hand up. Do you want to come in, Alex?
Yeah, I'll just come back to some of the questions around the modelling. So yeah, kind of what I presented was in many ways really just kind of a product of the data we had at that time and also the organisations that were able to support the work at that time. But both of those things have now changed, and what we're now able to do is take probably something that's more consistent with the public health approach that Lucy mentioned, whereby we are now looking at data on our population's health. We're able to kind of notionally segment people in line with things like our Live Well framework or various other kind of public health measures, population segmentation, and then start to measure the activity, the kind of costs associated with that activity of people in those segments, and also start to look at how that's going to change over time, so we can forecast how people will move into different segments as things like prevalence of long-term conditions change. So that's what we're doing now, and we're kind of working over that quite quickly over the next few months, and I think that will be a kind of a much better evolution of what we've presented, I think.
Okay, and Bev, did you want to come back again on that? You're on mute. Bev, you're on mute.
Sorry, apologies. Can you hear me now? We were in the same room, so I'm using Ben's speaker. So I put it in the chat, but it was basically the key bit around actually the focus on prioritisation, but also on targeted intervention. It isn't a blanket approach that is actually going to make this successful. And I couldn't agree more with Ruth's comments with regards to the fact of really understanding what impact actions you've already taken have had and where you should be growing those and where actually you should be considering the disinvestment point.
Okay, thank you very much. So I'm going to take a couple more comments. So I'm going to Andrew and then to Ruth.
Just as 2 questions together. So just coming back on capacity issue and the difficulty of this and difficulty of the headspace and difficulty doing it. I was working in Tower Hamlets over that time, and it didn't feel any less busy in the emergency department compared to anywhere else. So it always feels like there isn't time to do this. It always feels like you're as bad as anybody else. But when you step back and look at the numbers, actually you see what you are doing is making an impact. So just really sort of making the point, how it feels in the front line isn't always the best barometer of whether we're creating capacity or not, because you only see what's in front of you.
Okay, thank you very much. Ruth?
Interestingly, Andrew set me up for what I was going to say. I agree with you, and I think we can't not take the headspace to do this, and that's going to be challenging. I think we do need to remember what we've already done. We aren't starting from zero on here, and there's been a lot of stuff. But actually, just for a very small example, one of the interventions we've done, looking at how we can do something differently. So the Unscheduled Care Coordination Hub, absolutely fantastic piece of work and really, really well done. But what it's turned out is that one of the UCRS teams that have been doing some of that work has meant that they have had to do less of some other work. And so the capacity isn't just about people working hard, it's about actually the capacity. And we can't use our Christmas money 3 times. You only get to use it once. I think, and our people and our well-being and all of those things. So I do think we need to be really careful that we don't get too over enthusiastic. But that's not to say that I'm all doom and gloom. I'm really not. I'm really positive and happy to work on this, as is Paul Little. I saw in the chat. But we've got to do it properly.
Okay, thank you. That's a really good point, I think, to end on. So it is just a few minutes before 12, and people will have other things to get off to. So I'm going to close the discussion at that point. As I said, this was a discussion. This wasn't a decision we were meeting. It was really an opportunity to start to really explore the depth of this. I think we've done that really well this morning. As I said earlier, we are going to start to pull together some written products around this, and I'm beginning to wonder if maybe in a way, the same way that those of us who've got a memory going back a few years in the ICS, we've worked really well previously at co-producing some papers and strategies, and I'm wondering whether or not we start to do that in the system and start to put together some things which might take all sorts of drafts and all sorts of conversations to get it right. It's a tricky one to pin down, but we've made some progress this morning. So can I just thank, in particular, Bev and Ben for joining us from Carnell Farah. Alex, as ever, I always admire Alex for having even prettier slide decks than the ones that I produce. And thank you very much. And I'm going to hand over back to Will Pope, who's going to close the meeting.
Susanna, thank you very much. And what a great discussion. Actually, all morning, to be honest, some really rich discussions. But that latter discussion around the future integrated care strategy, demanding capacity and investing in community care, very, very strong. I sensed all the points made. I don't think an invalid point was made by anybody, which is great. But actually, all the points seem to be around the general theme that we agree this is what we should do. Now it's a question of how we do it, how we evidence it, what we include so that we get the inclusion of all, whether it's mental health, public health, children and young people and so on, and that we then stay evidence-based seems to be commonly agreed. So thank you for that. That was terrific. I'm going to close just in 2 ways. First of all, to ask if there is any other business. None has been raised with me prior. Unless any hands come up, I'm going to say there isn't. And then over to you, Susanna, for the next meetings, because I know you want to say a few words about what is coming up. So back to you.
So just to say that you will have seen, I've been sending out some diary invitations to yours, a few more to come. Formal meetings of the ICP this year will be every other month in this format online. I've sent out the diary dates for those. The next one of those is in April, and then every other month from there forward. You did have a date in your diary for Friday, the 8th of March, which I have now cancelled. So if that is still there, it did say Community Connect and ICP. If it's still sitting in your diary, then please, you can take that out of your diaries. I have cancelled it for mine, but sometimes the invitations wander and you might have that. In terms of other activities, in between our formal meetings, of course, there's lots of other things we do as an integrated care partnership. The next instalment of our current system learning programme, which is called Uncomfortable Truths, is on Friday, the 1st of March. It's at IP City in Ipswich, and all committee members of the ICP are, of course, invited, plus we can include other colleagues of yours where relevant. And I'm going to be sending out the agenda for that either today or on Monday. And then we have a Thinking Differently Together event in person, which is on Wednesday, the 20th of March. Again, I'll send that out to your diaries very soon, at Dance East in Ipswich, which is around supporting people growing up in care. So again, we're going to be sending out the agenda for that very soon. And then last but no means least, the date for Expo 2024 is set. I did put it up in the break. And I've sent round diary notes. It's Friday the 5th of July 2024, and lots planned for that, but I'd really welcome your ideas and contributions as we get into planning that. So, and we're all looking forward to it being as bright, hot and sunny a day as we've been fortunate to have previously. So that, back to you, Will.
Thank you, Susanna. I just noticed a quick question in the chat from Joe about the date in April for the next meeting. Do you want to just confirm that again, Susanna?
It's the second Friday of April, which is, I think it's something like the 12th.
Let me just have a see if I can find it first. Bit of a competition now to see if I can find it first.
Yes, it's the 12th.
It's the 12th, isn't it? Yeah, well done.
Yes.
That's great, all. Thank you very much. That's 12:02. A fantastic catch up. Well done, everybody. Rich debate, fantastic contributions, great integration, lovely work. Keep going. We've got a long way to go yet. Thanks all. Have a great weekend.
Thanks, Will. Thanks, everyone. Bye.
Thank you.
Thanks.
Okay, so